So drugs affecting cardiovascular function. Let us discuss antihypertensive drugs. So hypertension is of two types: primary or essential hypertension. It is idiopathic. There is no known cause. Secondary hypertension is due to underlying cause: renal, vascular, endocrine disorders, etc. So according to American Heart Association guidelines, greater than 120 mm systolic and greater than 80 mm diastolic uh, is basically hypertension. Less than that is normal. Okay, risk of cardiovascular disease increases with increase in blood pressure. So systolic, diastolic, pulse pressure, you know the meanings. So classification of antihypertensive drugs: first use diuretics, okay, then use dilators. So both arterioles and arteries and veins, you have ACE inhibitors, angiotensin receptor blockers, ACE, ARBs, aliskiren, direct renin inhibitors, and sodium nitroprusside. Only the arterioles, you have hydralazine, which is safe in pregnancy, and minoxidil, okay, K plus channel opener. And then for the veins, you have nitrates. Next, you can also use calcium channel blockers and beta blockers, and also alpha adrenergic blockers. Alpha adrenergic blockers, they depress the vasomotor center sympathetic outflow, due to which there is vasodilation, and also there is decrease in the contraction and all of the heart, so BP decreases. And calcium channel blockers, similar action is there. So in the vascular smooth muscle, they prevent contraction by blocking calcium. So what happens is that there is a peripheral vasodilation and the BP decreases. Okay, so this is the basic classification. So moving on to ACE inhibitors, they're the first line antihypertensive drugs. So mechanism of action is ACE converts angiotensin 1 to angiotensin 2, and ACE inhibitors, they prevent this step. So what happens is angiotensin 2 constricts the blood vessel, increases total peripheral resistance, which causes increase in BP. So this is prevented. So there's a decrease in BP when you use ACE inhibitors, and also aldosterone release causes Na plus and H2O retention. That is also causing increase in BP, but that is prevented in by ACE inhibitors. Cardiac hypertrophy and remodeling is also prevented by ACE inhibitors. So basically, ACE inhibitors decrease the sympathetic activities. They also inhibit degradation of bradykinin by ACE. Okay, so bradykinin is a vasodilator. They simulate the synthesis of vasodilating prostaglandins through bradykinin, and all of these have a antihypertensive effect. So ACE inhibitors are taken 1 hour before meals because food reduces the absorption of ACE inhibitors like captopril, and they are given orally. Liver metabolism, excreted in the urine, etc. So what are the contraindications and adverse effects? Remember it by the name itself: captopril, C for cough, A for angioedema, P for proteinuria rarely, and T for teratogen. Okay, O for hypotension, P for again neutropenia, R for rash, I for itching, and L again for loss of taste. Okay. So basically it is excreted through the urine, right? So in patients with bilateral renal artery stenosis or a single kidney, you can't give it because it increases stress on the urinary system. Okay, now moving on to the classification. So remember this: captopril, enalapril, and ramipril. Rami is rapid absorbed, okay, and duration of action: capto and enalapril is 8 to 12 hours, 24 hours, and ramipril is greater than 24 hours. Route of excretion is kidney. Okay, so that is about it. And what are the uses of ACE inhibitor, drug interactions? So Li, KD to NASA. Okay, lithium, dangerous hyperkalemia with potassium sparing diuretics. Okay, KD, potassium diuretics. Lithium toxicity. And ACE inhibitors and NSAIDs, they decrease the antihypertensive effect of ACE inhibitors. Okay, moving on to therapeutic uses. So it is used in everything related to the heart: hypertension, myocardial infarction, chronic cardiac failure, and also ACE, also related to kidney, right? So diabetic nephropathy. Next, angiotensin receptor blockers, Saradaga receptor block. So OMI, Omisartan, and Telmisartan and Losartan. Okay, they are given orally, metabolized in the liver, excreted through the urine and kidney, etc. So basically, they're competitive antagonists of the receptors, and they block the actions. That's how. And adverse effects: they cause hyperkalemia in renal failure. Again, they're used in hypertension, heart failure, myocardial infarction, and diabetic nephropathy. Okay. Direct renin inhibitor is aliskiren. Okay, so that is how it acts. Next, it causes diarrhea, nausea, vomiting, etc. And diuretics, you know how they act, right? Thiazide diuretics are used in uncomplicated mild to moderate hypertension, and they have a long duration of action. So they promote loss of water. Okay, so that is how the BP reduces, because cardiac output reduces. Okay. So adverse effects. So basically, loop loses all ions, but thiazide retains calcium. So there is hypercalcemia. Okay. So because of hypercalcemia, what happens is there's a decrease of fractures in the elderly. Next, advantages of thiazides: long duration of action, well tolerated by the patients, and decrease the incidence of fractures in elderly people. Loop diuretics, they have a short duration of action and they cause hypo of all ions, right? Loss of all ions. So those are the adverse effects. So calcium channel blockers, what do they do? So you have verapamil, diltiazem, and dihydropyridines. They are useful in all grades of hypertension. Okay, it is mainly due to peripheral vasodilation. So antihypertensive effect. So they cause headache, ankle edema, palpitation, and reflex tachycardia. Okay, beta blockers can be used with calcium channel blockers. Okay, beta blockers, calcium channel blockers to counteract the reflex tachycardia. Okay, next, sympatholytics. What did you have? Selective and non-selective ones. Selective beta blockers include atenolol and esmolol. Okay, and non-selective ones include propranolol. So what happens is, basically beta blockers, they decrease the working of the heart, so decrease the cardiac output. Initially they cause increase in peripheral resistance, but chronic therapy, they decrease it. Okay, what do beta blockers do? They decrease the sympathetic outflow, reducing the BP. They decrease renin release, and they also cause all kinds of negative effects on the heart, so decrease in BP. So you have sympatholytics again. So what are the sympatholytics? You have clonidine, which is a centrally acting hypertensive drug. It is effective orally. Okay, transdermal patch controls BP for a week. Okay, what are the adverse effects? So clonidine, dryness of mouth and eyes. Sympatholytic, right? So it causes less saliva, sedation, depression, bradycardia, and all the parasympathetic things. Next, sudden stoppage causes clonidine withdrawal symptoms. This is due to supersensitivity of receptors and previously release of a large amount of stored catecholamines. Clonidine, it is useful in okay, pregnancy. Then P for pre-anesthetic and P for prophylaxis of migraine, and also postmenopausal flushes, it decreases them. It is also used in hypertension. Okay, clonidine is a pro. Next, alpha methyl dopa also similarly. So what does clonidine do? Just like beta blockers, alpha lytic, right? So sympatholytic, what it does is vasomotor center, it decreases sympathetic outflow. Beta blockers, they acted on the heart and kidney. Okay, but here alpha blockers, they act on the vessels, vasomotor center, alpha, okay, blood vessels, and also the heart. And again, you have alpha adrenergic blockers, such as selective and non-selective ones. Non-selective ones include phentolamine, and selective ones include prazosin. Again, they all block the alpha 1 receptors. Alpha 1 receptors, when blocked, it causes vasodilation and fall in the BP. Okay, prazosin primary dose causes postural hypotension. It is selective. Next, you also have other vasodilators such as minoxidil and diazoxide. Minoxidil activates K+ channels. It causes hyperpolarization of vascular smooth muscle, resulting in vasodilation and decrease in blood pressure. Minoxidil is also used as a diuretic and also for hair growth. Okay. Next, hydralazine, it is safe in pregnancy. So basically it is an arteriolar dilator which reduces the BP. Reflex tachycardia again. Sodium nitroprusside, both powerful arteriolar and venodilator. Nitro, it is active at night. Okay, so it is active at dark. So it should be kept in a dark bottle. Sunlight destroys it. And it has a short duration of action. Okay, so it releases nitrates. Okay, and it is also that is how it is used. So basically sodium nitroprusside generates nitric oxide. Okay, venodilation causes a decrease in the preload and cardiac output and hence BP. Arteriolar dilation reduces the afterload and hence decrease in BP. Nitroglycerin is primarily a venodilator. Next, treatment of hypertension. So basically non-pharmacological approaches are weight reduction, sodium restriction, alcohol restriction, exercise, and mental relaxation. Okay, sodium poor and potassium rich diet. And drug therapy. See, first remember one thing: hypertension, hypertensive crisis, hypertension in pregnancy, hypertensive crisis in pregnancy. In pregnancy, use only labels. So labetalol, okay, beta blocker, which is safe in pregnancy. Hypertension, okay, drug of choice is thiazides. Okay, hypertensive crisis, use N, that is nifedipine. Okay, nicardipine. Okay, so start in hypertensive crisis, basically 120/80 should be normal. 180, 120, it is hypertensive crisis. So use nicardipine and labetalol in pregnancy if it's a hypertensive crisis, and also sodium nitroprusside, nitrates immediately. Okay, this is all about hypertension.